Welcome to another session of dentistry and more. So we'll be continuing with oral medicine and radiology topics. Under that, we are going to speak about oral radiology as such. We can refer this for the topics. You can refer the textbook from Freni Karjotkar as well as White and Farrow. So today's topics that are going to be discussed are the properties of X-ray, production of X-ray, radiation biology, and the protection from radiation. So under the chapter of properties of X-rays, it has been beautifully been explained in Freni Karjotkar. Once a question is being asked in regard to the properties of X-rays, you can refer from Freni Karjotkar. They have divided into 4 parts, that is the physical, chemical, as well as the biological, physico-chemical properties. So you can explain each of these points that has been given in the textbook itself. Once the question is asked about the discussion in regard to the production of X-rays, we must start off with the diagram itself, the diagrammatic representation of the X-ray tube head. So within the X-ray tube head, you have a cathode and an anode. In the cathode, you have the filament, whereas it has been embedded in a focusing cup. And then on the anode, you have the copper stem, in which you have the focal spot where the target is being hit against. And then from there onwards, the X-rays are being directed in all the directions, but it passes through across the unleaded window through which the useful X-rays are being passed, and it is being hit against the patient or the tooth of interest, and then it hits the film. So once we speak about the production of X-ray, we start off with the electricity from the outlet in which the X-ray machine is being turned on, and then the current from there it enters to the control panel, wherein it through the step down transformer it tries to reduce from the line voltage of 110 to 220 voltage to 3 to 5 volts, and then from there the filament in the circuit tries to go through the incandescence, or it tries to heat up the tungsten filament through this limited voltage, that is 3 to 5 voltage, and from there it tries to form a thermionic emission, in which the thermal energy, that is the heat incandescence of the filament itself, heats up to form the electrons, and from there the electron cloud is being presented, and from then the exposure button is being pressed in such a way that the high voltage circuit is being activated, and the filaments by the heating up of the filament, it tries to eject all the electrons to form this electron cloud with the help of the molybdenum cup, which tries to direct the electrons towards the target, that is the placed in the anode. So the target is nothing other than a tungsten based material. Why this tungsten based material is being utilized is because of the 4 properties. It has a high atomic number, so it tries to produce X-rays, efficient X-rays. The atomic number is found to be 74, and then it has a property of high melting point, which can withstand any heat that is being produced during the X-ray production. And then other property is the higher thermal conductivity. It helps to dissipate the heat that is being produced away from the target. And then the 4th property is the low vapor pressure, in which it helps to maintain the vacuum in the tube at a high operating temperatures. So once it hits the target, what happens is that the electrons, the kinetic energy that is imbibed within the electrons, have been converted to an X-ray energy, as well as heat is being dissipated. The dissipated heat is then caught up by the copper stem in the anode, and it is also later been absorbed by the insulating oil that is present within the glass envelope, and the X-rays are being produced in such a way that it is directed in all the directions. And once the unleaded housing that has been seen, the unleaded envelope that has been noticed in this X-ray tube head, it is through this the X-rays are being passed across the collimators as well as the filters, and then these X-rays that are being produced is hit against the tooth of interest or the site of interest, and then it hits the film. So the second question is about describe the production of X-rays, which has been explained previously, and then discuss about the factors that control the X-ray beam. So the factors that control the X-ray beam has been explained well in White and Farrow textbook itself under the chapter of radiation physics. In that you have the exposure time, the milliamperage or the tube current, as well as the peak tube voltage that is considered as the tube voltage itself, and then the collimators, the filters, as well as the target to image receptor distance. So these are the factors that can control the X-ray beam. In the exposure time, that is in seconds, it is the change in the exposure time which helps to measure the duration of the exposure and also the number of photons that have been generated during this exposed time. So this helps to control the X-ray beam production, and the tube current is found to be equivalent to that of the beam quantity. What it means is that the beam quantity is that the number of photons that have been emitted in an X-ray beam has been noticed through the tube current, which is in the form of milliampere. So more the number of photons that have been generated is through the number of photons that have been generated is increased by the increase in the milliamperage. Next is the tube voltage, that is a peak kilo voltage, and in this it is found to be interrelated to that of the beam quality, that is the X-ray beam quality, which means the mean energy of this X-ray beam, that is the kinetic energy that has been emitted by these electrons are being utilized by the help of this beam quality through the help of peak kilo voltage. This peak kilo voltage increases when there is an increase in the number of photons generated, and it also helps in increase in the mean energy of photons and then the maximal energy of the photons. Next, we is going to speak about filtration. In that, filters that have been used as the aluminum filters. In this, the X-ray beam that has been emitted from the target anode is being passed through the unleaded glass window. First, it interacts with the filters and then with the collimators, and through that, the X-rays are being passed out. So, the function of the filters is to remove the low energy photons from the X-ray beam. So what it does is it tries to eliminate all this unwanted X-ray beam that is to interact with the tissue or the film itself. So in that, the filters that are being utilized is the inherent filtration, the added filtration, as well as the total filtration. And that inherent is nothing other than your vacuum or the insulating oil that is placed within the glass envelope of the X-ray tube. So that acts as the inherent filters. And the added filters are the aluminum disc or the filters that have been utilized in front of the X-ray tube head itself. So in that, the total filtration is considered to be both, that is the inherent filtration, that is the inherent filtration, as well as the added filtration together makes up the total filtration itself. So the total filtration that we see is that around 1.5 mm of aluminum is being used for operating for a machine of 70 kVp. So if it is the in high voltages machines, in that the thickness is being increased, that is to 2.5 mm of aluminum discs are being utilized. Next is collimation. Collimation is nothing other than a metallic barrier with an aperture in the middle itself, and the function of this collimation is to reduce or restrict the shape and the size of the X-ray beam such that only the required beam of X-rays is being utilized to be irradiated for that volume of tissue. And in collimation, the material of use is the lead itself, and in that we have two types of collimators, that is a circular as well as a rectangular collimators. The rectangular ones are more preferable because it tries to limit to the size to that of your intraoral receptor itself, because intraoral receptor is also rectangular in shape, so it tries to reduce the X-ray beam to that size itself. And next is about the target to image receptor distance. It follows this law called as the inverse square law. In the inverse square law, it is nothing other than the intensity, that is the number of photons per square cross sectional area per unit of exposure time, is found to be inversely proportional to that of the distance from the target to the image receptor. So if the intensity is more, there is a reduction in the distance between the target as well as the image receptor. So this is a law that is being followed in the target to image receptor distance. So these are the following factors that can control the X-ray beam production. Next is about the short notes on Compton scattering. What do you mean by Compton scattering? Compton scattering, its other name is called as the inelastic scattering. It comprises of around 57% of the whole of the X-ray beam that is being produced. And in that, the Compton scattering, what it does is that an incident photon, it interacts with an outer electron, and then it produces a scattered photon of a lower energy than that of the incident photon itself. And then what happens is that the electron recoils as ejected from the target atom, and the new scattered photon travels in a very different direction from that of the incident photon. So the ejected outer shell is then called as the Compton or the recoiled electron itself. So the angle through which this photon is scattered, it depends highly on the energy that has been lost by the photons. So this is a diagrammatic representation to explain what is Compton scattering. You can see here the incident photon, it interacts with the outer shell electron, and this electron gets recoiled in the form of recoil electron or a Compton electron, and the angle, it highly depends on the energy of the how much of the energy is being imbibed for this electron to get recoiled. Next is the types of interaction of X-rays with matter. This is well explained again in White and Farrow textbook under the chapter of radiation physics itself, with all the diagrammatic representation for all the types. That is, the three types are there. That is photoelectric effect, coherent scattering, as well as a Compton scattering. Coherent scattering, that has already been explained previous slide itself. Next is I will explain about what is photoelectric effect. In photoelectric effect, it comprises of around 27% of all the photons that have been interacted with the object. So that object is nothing other than the patient or the tooth of interest itself. So in photoelectric absorption, what happens is that the incident photon, it gives up all of its energy to an inner electron, which is ejected from the atom in the form of a photoelectron itself. Then this incident photon, it ceases to exist at this point. What happens next is that the ionized atom now has an electron vacancy in the inner orbital. So it tries to occupy this vacancy from the outer shell itself, the electron. So an electron then subsequently fills up this vacancy and it emits also a characteristic radiation. So all the orbits are then filled. So the complete energy exchange occurs in this photoelectric effect. So this is what is about photoelectric effect, and next is about the coherent scattering. So in coherent scattering, what happens is that here the interaction of a lower energy incident photon, it interacts with the whole atom as such. So what happens to the whole atom? It tries to momentarily get excited, and after this interaction, the atom quickly returns to the ground state itself. It comes back to the ground state, and then it emits a scattered photon of the same energy but at a different angle from the path of the incident photon. So that is what the difference between the coherent scattering with that of the Compton scattering. And then the coherent scattering, it comprises around 7%. Next is about the production of X-rays, which has already been explained when asked as a long essay. What is the production of X-rays? You have to speak about the X-ray tube head and everything, and then the sequelae or the you can give a flowchart as to describe how the X-rays are being produced. That is a long essay that can be asked under this topic. Next is about the collimators and filtration. The collimators and filtration, already that has been explained in the factors controlling the X-ray beam itself. I have explained what are collimators, what are filters. Again, I'll re-explain it. In this, you can see that through the X-ray tube head, the unleaded glass window, first the X-ray beam interacts with the aluminum filters and then with the collimators. So the aluminum filters, that is the added filters that are being placed in front of the window, that is the unleaded window itself, it tries to remove all the low energy for X-rays from the spectrum before reaching to the patient. So the filtered X-ray beam is equal to that of the reduced photon intensity plus an increased X-ray beam energy. So the types of filters are the inherent filters, added filters, and the total filters, as I've already explained in the previous slide itself. And collimators are nothing other than it functions to restrict or even reduce the shape and size of the X-ray beam so that it can concentrate onto the patient with or the tissue that is supposed to be radiated. Thus, it tries to reduce the exposure to the patient. So there are two types, that is the rectangular and the circular ones or the round ones. So rectangular collimators are more preferable because it tries to limit towards the image receptor size itself. Next is about the Bremsstrahlung radiation that can be asked as a short note. Bremsstrahlung is a name, there's a German name meaning breaking radiation. What happens over here is that when there is a direct collision of the electrons to that of the target nucleus, or the electrons which come close to the nucleus, it results in an electrons that are deflected or decelerated. So what happens most of the time is that there is a passage of an electron near the nucleus and it results in an electrons which are being deflected or decelerated. So what happens most often in Bremsstrahlung radiation is that there is a passage of an electron near a nucleus which results in an electrons which are being deflected or decelerated. So that is what is called as a breaking, or it breaks the radiation once it comes near to the nucleus. That is why it's called as a breaking radiation. Next is chapters about radiation biology. Under this, the most favorite question that can be asked in short notes is the deterministic and the stochastic effects. In this, you can refer again from White and Farrow textbook. They have already given a tabular form of what is deterministic effect and what is a stochastic effects. In deterministic effects, it is found to be caused due to cell killing, whereas the stochastic effects is found to be caused due to the sublethal DNA damage. In deterministic effects, the severity of the response is directly proportional to that of the dose, whereas the severity of the clinical effects is independent of that of the dose, and it follows the all or none response, wherein an individual either manifests the effect or does not in the case of stochastic effects. Next is about the deterministic effect, that is the relationship between the dose and the effect. There is a probability of the effect which is independent of dose in cases of deterministic effect, whereas in stochastic it is found to be proportional to that of the dose. And the examples that can be cited for stochastic effects are the radiation-induced cancer and radiation-induced skin cancer or heritable effects. That is the some gene mutation that can occur, which can be hereditary, can be passed on from the parent to the offspring, is what you can consider in the stochastic effects. Whereas in the deterministic effects, those are the examples that can be cited as the radiation-induced cataract formation or the radiation-induced skin burns. Even osteoradionecrosis is considered to be an example for a deterministic effect. Next question that can be asked is the deterministic effects of radiation on oral structures. So in oral structures, you can see there is oral mucositis, sloughing of mucosa, secondary infection that is secondary to candidiasis, which can lead to whitish to yellowish pseudomembrane formation, that are oral ulcerations that can be seen, and also atrophic thin avascular mucosa. Among the taste buds, there is found to be a loss of taste sensation in the third or the second week of radiotherapy. Whereas in the salivary gland, there is a decrease in the salivary flow. The composition of saliva is affected in such a way that it tries to lose its lubricating property. There is dry mouth or xerostomia. There is pH that has been decreased. It's more of an acidic saliva. And also, there is a compensatory hypertrophy of salivary gland ducts. Among the teeth, there is a development of teeth is found to be retarded. Prior to calcification, the tooth buds are found to be destroyed. Pulps are found to be having decreased vascularity and cellularity, which can lead to pulpitis, and there is radiation caries. Among the bone, there is a condition called as osteoradionecrosis, which is caused by the 3H principle, that is hypoxia, hypocellular, and the hypovascularity, which can lead to pathologic fractures. Management of radiation-induced mucositis. So how to manage is mostly it's found to be a symptomatic relief, that is pain controls are being given, analgesics are being advised, and a nutritional support, that is by prescribing certain vitamins and minerals are being prescribed for oral mucositis. Oral decontamination by the help of use of any antimicrobial mouthwashes, and then the palliation of dry mouth, management of oral bleeding, as well as therapeutic intervention for the oral mucositis with the help of any salivary silagogues or any salivary substitutes. Next is the question that can be asked is the radiation caries. Radiation caries is nothing other than a rampant form of caries, wherein it is caused secondary due to the changes in the salivary composition that I have already explained in the previous slide. when I have mentioned about the radiation induced mucositis. Over there, I have mentioned that there is a decrease in the pH or levels of saliva. There is also decreased salivary flow. There is a lubricating property that has been affected and an increased viscosity of saliva, which can lead to this radiation caries of three types. The three types are: the first type is the cementum and the dentin that is involved in the cervical regions. Second is a generalized superficial lesion which can attack the buccal, occlusal, incisal and the palatal surface. And the third type is a generalized pigmentation that is seen. You can see a darkish black pigmentation that is covering the whole crown portion. The next chapter is about the protection from radiation. When the question in regard to discuss the radiation hazards in dental radiology is being asked, you can speak about the sources of all the radiation that are seen or the radiation exposures. So you can speak about in that. It is already mentioned in the safety and protection chapter in White and Farrow itself. In the first pages itself, they have mentioned about what are the radiation hazards in dental radiology. When you can speak about the terrestrial radiation as well as the medical exposures that can lead to this radiation hazards. Next is how to manage it. Management is by reducing the dental exposure and proper patient selection. That is, we follow the principle of justification. That is, in implementing a radiation protection, there are certain guidelines for that. So there are the three guidelines for the radiation protection, that is justification, optimization and dose limitation. So improper patient selection means justification of why the dentist is prescribing or advising a radiograph for such a patient to be taken. So is it a necessity or not? That is what is considered for in the principle of justification. Then the choice of equipment, then followed by the intensifying screens and grids that are being utilized, proper source to skin distance, which I'll be explaining in the next following slides. How much is the distance that is required and how much is the distance the patient and the operator should stand, followed by the proper source of image, receptor and distance. And then the collimators and filters also play an important role in reducing the radiation exposures. And to reduce exposure for the patient, we always ask them to or advise them to wear the lead aprons and collars, and the films and the sensor holders and shielding. That is, shielding can be done for the patient with the help of these lead aprons and for the radiograph rooms, we try to place wall mounted lead or the lead shields have been utilized for protection for the operator from that of the X-ray exposure. One of the favorite questions that can be asked in short note is the ALADA principle. It's also called as ALADA or ALA is diagnostically acceptable, or ALARA means as low as reasonably acceptable. So it follows, as I said, there are three guiding principles in the radiation protection, that is justification, optimization and dose limitation. So ALARA principle follows the optimization principle, that is, it holds that the dentist should use every reasonable means to reduce unnecessary exposure to the patient, staff as well as themselves. That is why you follow this rule. Next, the question that is asked is discuss in detail the protection measures to be adopted by both, that is the radiation personnel and also the patient. So the operator protection guidelines that are being followed is nothing other than the operation protection guidelines, such as that of the shielding that is being utilized and the construction of the radiology room with the lead walls being mounted. And then you have to follow the rule of the distance of the operator from that of the X-ray exposure, that is around 6 feet away from the X-rays that have been exposed, and also at an angulation of 135 to 90 degrees from that of the X-ray tube, that is, or the X-ray being directed. Patient protection, that is prior to exposure, prescribe the dental radiographs that is only required for the patient and proper equipment is being utilized. During exposure, the patient is being advised for wearing the protective shield, such as that of lead aprons, the lead collars or the thyroid collars as well as the gonadal collars. And also the technique that is being utilized, which is required for that X-ray to be exposed. And after exposure is the film handling and the film processing should be dealt with carefully. Next is the protection for the other people, that is based on the design of the radiology room as well as the construction of the radiology room. As I said, the walls have been mounted with lead. Short essays that can be asked is the quality assurance and the infection control in dental radiology. In quality assurance is defined as a program for periodic assessment of the performance of all parts of the radiographic procedure. So this is highly intended for the dental office consistently to produce a high quality images with minimum exposure to the patients as well as the personnel. So what we do is that we go through a survey during the installation period, and also we do the resurvey in every 4 years. The film processor should be evaluated every month in addition, and the processing chemistry should be evaluated daily, so that each type of film that has been evaluated should be evaluated on monthly basis, as well as a new box or the batch of film that has been opened has been evaluated. Also, the lead aprons and collars are also inspected visually so as to avoid any damage towards it. That is, on monthly basis you have to visually inspect it. The next short note that can be asked is the Thermoluminescent Asymmetry, that is TLD badges. TLD badges, what the function is such that you have to check how much is the dose that has been taken up, and within 3 months it has been evaluated. In that, what the function is such a way that once the radiation strikes, the luminescent materials that is being utilized, that is a luminescent material here is the lithium fluoride, the electrons are being raised to the higher orbital levels. Once they get back to the original orbital levels, the light has then been emitted. So the light that has been emitted is found to be directly proportional to that of the radiation intensity. That is what the function of the thermoluminescent dosimetry is. Next is a personal protection in dental radiology that already have been explained in the previous slide. Personal shielding is nothing other than the lead barriers that have been utilized of 1.5 mm, and also lead aprons and gloves of 0.25 mm thickness has been utilized. For the gonadal shield, thickness of 0.5 mm has been utilized, and other radiation protection that has been utilized for any specialized investigations. And the patient shielding is nothing other than, again, the thyroid, the gonadal as well as the lead aprons have been prescribed for or advised for the patients to be protected from any X-ray exposures. The position distance rule that can be asked as a short note. So you have to draw a diagram representing what the position distance rule is. Here the operation is standing at least 6 feet away from the X-ray tube or the central beam of X-rays that has been produced, and from there at least an angle of 90 to 135 degrees is been operator should stand away from the central X-ray beam. Thank you for this session. We'll be continuing for the next. Welcome to another session of dentistry and more. We'll be continuing with the question paper discussion in oral radiology. So today's topics that will be discussed are the ideal and the faulty radiographs, X-ray film and accessories, processing, then the intraoral radiographic technique and the extraoral radiographic techniques. Under the chapter of ideal radiographs, which you can refer from Freni Karjotkar itself, they have a huge chapter about it itself, the ideal radiograph as a chapter as such. Once a question has been asked relevant to ideal radiograph, you should start off with the definition. It is one that provides a great deal of information. The image exhibits proper density and contrast, have sharp outlines, and are of the same shape and size as the object being radiographed. And then you should talk about the attributes to have an ideal radiograph. Those are the density, contrast, resolution, sharpness, and the speed of the film. So all these categories you have to speak about what are their definitions, that is density, contrast, resolution, sharpness and speed, followed by what are the factors that can lead to an ideal radiograph, which has been explained well in the chapter An Ideal Radiograph by Freni Karjotkar. So next chapter is about the faulty radiographs. Under faulty radiographs, the first question that can be asked is, what is an X-ray film processing? Describe the composition and function of the processing solutions, and then discuss the causes of faulty radiographs. The first part of the question that I'll be explaining the further slides. Here I've just mentioned what are the processing solutions, that is you have a developing solution and the fixer solution. and in that you have to speak about the composition of each of the solution. That is, in the developing solution you have the developer, you have the activator, preservative, and then the restrainers, whereas in the fixer solution you have the clearing agent, the acidifier, preservative, and the hardener. So what are the composition or the ingredient for each of this and the function that should be described well? It has already been given in the textbook of oral radiology by White and Farrow, where they have explained under the chapter of film imaging. Under that they have spoken about the components and functions of each of the solution, so you can describe in detail. So here I've just mentioned what are the contents in the developing solution. You have a developer, activator, preservative, and the restrainers, and each of the ingredients in the developer, that is phenidone and hydroquinone. Then you have in activator you have the sodium hydroxide and the potassium hydroxide. Then the preservative is the sodium sulfite, and the restrainer is the bromine containing compounds. So each of the ingredients functions that should be highlighted in this answer. Same going on with the fixing solution itself. Even in the fixing solution you start off with what are the components, that is you have the clearing agent, acidifier, hardeners, and the preservatives, and the ingredients related to that, that is clearing agent you have the ammonium thiosulfate, then you have an acidifier, you have the acetic acid, preservative is the ammonium sulfide, and hardener is the aluminum sulfate. So what are their functions that should be described in detail to answer this question. So the further question that has been asked are the discuss the causes of the faulty radiographs. So here are the list of the causes for the faulty radiographs. Again, there's a chapter called faulty radiograph in the textbook of oral radiology by Freni Kajokar, where she has mentioned about what are the causes for the faulty radiographs, starting off with the 4 causes, that is projection errors, exposure and processing errors, then you have the miscellaneous technique errors, and the automatic processing errors. So under the projection errors, they have enlisted all the errors with their cause as well as how to correct them. So have a read about each of these error, that is apical lens of the tooth is being cut off, then you have the occlusal plane that isn't being tipped or tilted, all of the specific areas are not seen, herringbone effect, or the tire track appearance. This can be asked as a short note too, that is herringbone effect is nothing other fish bones that is seen by the name of the fish is the herring fish, where the bone is found to be almost looking like a tire track appearance. What is the cause of it is because the film is placed opposite side, it is not placed on the right appropriately. That is normally your film is, you can see that you have a white surface as well as the envelope surface of that, you will see there is a blue and a white color. So the white surface that you see is where you are facing it towards the X-ray exposure. So once what happens in this is that you have in the composition of film you have a black film, and also within the film you have a black film as well as a lead foil film is also being placed. In that the lead foil is placed near the back side of the enveloped cause an X-ray film. So what happens in that, you have, if you open, once you try to expose a film, when you try to process it, you might notice in the lead foil itself there are these kind of tire track appearance that you see with one end. So what happens is that once you try to place the film and not in a position, it is placed opposite way around, this tire track appearance is seen first, because once the X-ray is exposed, it is found to be enclosing, or it is found to be attracted towards the lead foil, and then it surpasses to the X-ray film. So that is why at first itself you can see this lead foil film wherein they have this kind of a tire track appearance has been resembled over to this film when it is being placed in the opposite way around. So that is why it's called as a tire track appearance or a herringbone effect. Then in the projection errors you have the crowns that are not shown, the partial images. Why is the reason of the partial images? It can be caused because of while your tube head is being placed not sufficiently positioned, or else it is positioned in such a way that your film is also being positioned improperly, where it is not coinciding with your tube head itself. So it can lead to a partial image. And then you have the overlapping of the teeth, that can be caused because of the improper horizontal angulation. As you know, the horizontal angulation, you should pass across the contacts in such a way that it is perpendicular to the contacts of the tooth. So once that is not being followed, there is this kind of an overlapping of the tooth. And then you have shape distortion, artifacts on it, double images on the radiograph. Why the double images are being seen? It's because of the case where you're exposed to the film twice. That can also lead to double images, or the patient's position is being differing. So that is when you have this kind of an error. And then you have the blurred image, and then there's something called as cervical burnout, with the other name is known as the as an adumbration. So cervical burnout or adumbration, it's nothing other than apparent radiolucency that you see below the cemento-enamel junction of the root. Almost in the contact areas itself, you will see this kind of a variation, because the root formation that you see in certain posterior tooth is that it is found to be concave. So it is more of an optical illusion kind of uh, a variant that you see, an error that you see. So this is then can be asked as a short note or a short essay itself, that is adumbration, or the other name is cervical burnout. Next you have is the exposure and the processing errors, and that you have all this exposure errors, what is that low density film, high density film, the high contrast and the low contrast, fog, streaks, blisters, frilling, you have white spots and the black spots, clear film and the black film. All those things you can, it has been explained well in Freni Karjodkar, what are the cause and how to correct it. So have a read about it. And in the miscellaneous technique errors, you have the phalangioma. Phalangioma is nothing other than the patient's finger is being placed between the X-ray that is being exposed and to the film. It is between these two areas, your fillers and your fingers being placed. That is when you notice this kind of a error, that is phalangioma. And what next is the automatic processing errors. In that again, there is a decrease in the film density, increase in the film density, there's streaking, fogging, peeling of the emulsion, there's sometimes the pressure marks that are seen, also there may be a white cloudy appearance that are observed, scratches on the X-ray film itself surface. All these you can read it about from Freni Karjodkar itself under the chapter of faulty radiographs. So the next chapter is about X-ray films and the accessories. In that you can read from the textbook White and Farrow itself, wherein film imaging chapter. In that you have the composition of the X-ray film, which consists of the base, the adhesive, and then the emulsion. The base, it is formed of the polyester polyethylene terephthalate. It helps to support the emulsion itself, and also it provides the degree of flexibility to easy handling of the film. And emulsion, it comprises of the silver halide grains and the vehicle itself. So the silver halide crystals that are found is mainly composed of the crystals of silver bromide. And then the vehicle, here what happens is the silver halide crystals have been, or the grains have been suspended into this vehicle, and it is found to be applied in both the sides of the supporting base. So this diagram also can be seen, the X-ray film under the chapter of film imaging in White and Farrow. Even you can refer in Freni Karjodkar also, they have mentioned it about the composition of the X-ray film, what are the components in it, and also what are the functions. That is what you should mention under this question. Next is about the X-ray films that have been used in the dental radiology. So we have intraoral films, that is a periapical films, wherein you have size 0, size 1, size 2, and the size 0 that is mainly meant for pedo or the children itself. So the size is around 22 to 35 mm, 22 into 25 35 mm, and whereas in the size 1, that is it is found to be used normally for the anterior teeth. So in that you have the size about 24 mm to 45 mm, and then you have size 2, that is the adults film, wherein the standard ones that we use is the 30.5 into 40.5 mm in size. And then the next you have the bite wings, wherein for smaller size for the children you prefer the size 0, and bite wing films you use for the adults as a size 2 itself. And then there are also size 3 for the longer ones that are available. You have for the occlusal films, there is size 4, which is found to be 3 times larger than that of the size 2, and that can be used for the maxilla as well as the mandible. So, and then you have the extraoral films, that is around 8 into 10 inches in size, and all the extraoral films are being utilized for the extraoral radiography. Next is about the filters in dental radiology, which I have already explained in the previous session. What are the filters that have been used? Here we use the aluminium filters, which is found to be 0.1 mm in thickness, and we have the 3 types, as inherent filters, added filters, and the total filtration. Inherent, as I said earlier, it is the insulating oil as well as the vacuum, which is found within the glass tube itself head. And then you have the added filters, that is the aluminium filters have been added on with a thickness of 0.1 mm thickness, and the total filter is nothing other than the combination of both the inherent as well as the added filters. So the main mechanism of filters is nothing other than to remove all the low energy photons, which can have a low penetrating potential, so it can compromise the image quality. So that is why it has been utilized, the filters. Then we have the intensifying screens that can be asked as short notes. So intensifying screens, most commonly it's used for the purpose of extraoral radiographs itself. The function of the intensifying screens is that it creates an image receptor system in which it is found to be 10 to 60 times more sensitive to X-rays than it is to the film alone. So what it occurs is that it helps to reduce the dose of X-ray radiation for the patient. So these intensifying screens have been used for the extraoral radiography, as I've earlier mentioned, and the composition of this, it is again given in the textbook by White and Farrow, wherein the diagram has also been given how the intensifying screen has been composed of. That is, it contains the base, the reflecting layer, phosphor layer, and the protective coating. So the base is comprising of your polyethylene terephthalate, and then the reflective layer where it contains the titanium dioxide, and the base normally it helps to mechanically support the other layers, and it is also having a reflective property wherein it reflects the light emitted from the phosphor layer back towards the X-ray film. And also this reflective base, it has the potential to increase the light exposing the film and also results in some kind of a image unsharpness. So what happens is that because of the divergence of the light rays reflected back to the film, it tries to bring out this quality. And the phosphor layer, it's composed of the gadolinium oxysulfide terbium or activated, or the yttrium tantalate, and also niobium activated ones, wherein it tries to reflect those where light of green or the blue wavelength lights have been reflected upon. So these phosphor crystals have the mechanism of fluorescence, wherein it can be increased by addition of certain small amounts of elements such as that of niobium, terbium, thallium also. So these have been the rare earth screens that have been used to convert the absorbed X-ray photons into a low energy, that is 4000 low energy levels of visible light is being produced. It helps to convert the X-ray photons to light photons. Grids, these are found to be used in the extraoral radiography, wherein it helps to improve the image quality by reducing the scattered radiation, and it helps to improve the quality of the image also. So it reduces the repeated chance of exposure. That is why grids have been utilized in extraoral radiography. So this is the diagram for that, grids. So the composition of the grids is found to be alternating strips of lead and plastic, wherein lead is found to be radiopaque and the plastic, as you know, it's radiolucent. And there are different types of grids, that is linear focused, pseudo focused, crossed, as well as the moving grids. Collimators, as I've already explained in the previous session, what are the collimators? Collimators are nothing other than a metallic barrier with a central aperture when it helps to restrict or reshape the size of the X-ray beam. So it reduces the patient exposure and unwanted tissue irradiation has been avoided in this. So it's kind of a, it helps to protect the patient from unwanted exposures. And you have the other types, that is you have two types, that is tubular, rectangular, even diaphragm kind of types are there in collimators, and rectangular collimators are more preferable. Next chapter is about processing. The question can be asked in processing is what is latent image, and then describe the process of formation of latent image, describe in detail the steps involved in manual processing of radiographs, and then add a note about the processing errors. So the processing errors part we have already mentioned. Now we just have to talk about what is a latent image. So the definition of latent image has been given again in Freni Karjotkar itself, wherein it is found to be a radiographic film when it has been exposed to the information carrying beam of X-ray photons exiting an object. The photosensitive silver halide crystals in a film emulsion interacts with these photons and are chemically changed, and these chemical altered crystals are said to constitute the latent image of the film. So once the question of the second sub question is the describe the process of formation of latent image, you can start off with a diagram like this that has been given in white and Ferro again. So once how the latent image formation occurs is such a way that we have a crystal lattice, that is the silver bromide crystal lattice in the X-ray film that is placed in the emulsion of the X-ray film, and you have the silver as well as the bromide ions that are found to be forming this crystal lattice. And within this free interstitial silver ions, there are some traces of chemicals such as that of sulfur ions have been used so as to form a sensitive sites that you can see here. So there is a sensitivity site over here. What happens now is that X-ray photons one has been exposed. It tries to interact with the bromide crystal, wherein it recoils an electron, wherein it has a sufficient energy to move about in the crystal lattice. And then what happens, these electrons are being attracted towards the sensitivity site, and what happens over there, it tries to impart a negative charge to this region, as you can see in this diagram. And what happens over here, this silver ions, that is silver has a positively charged ion, it gets attracted towards a negative charge that is seen around the sensitivity site. So then what happens here is that this tries to move towards the sensitivity site and tries to form a silver atom, and this silver atom once it is formed, this forms the latent image formation. And when this silver ion reaches this sensitivity site, what happens is it acquires this electron and forms a neutral silver atoms. Then this collection of the latent image sites over the entire film constitutes a latent image. And once the developer has been exposed to this for processing, what happens over here is that it causes the neutral silver atoms at the latent image sites to initiate the conversion of the silver ions in the crystal to form a metallic silver. And then in the developer itself, the bromine itself tries to dissolve within the developer. The next sub question is about the describe in detail the steps involved in manual processing of the radiographs. You can refer again from White and Farrow textbook itself. There are around 9 steps that they have mentioned about how the manual processing of the radiographs have been taken. And if the question has been asked what are the different types of manual processing of radiographs, you can again read from Freni Karjotkar, where they have mentioned there's a time temperature method, there is visual method, there is rapid chemical processing methods. All those can be mentioned under the chapter under this topic of the different types of manual processing techniques. And manual processing procedures, as I've said, you can read from White and Farrow textbook under the chapter film imaging itself. There are around 9 steps that they've mentioned. You can read about it, how the manual processing is done. That is, first is replenishing the solutions, then stirring the solutions, then it goes by mounting the films on the hangers, followed by checking for the timer and the temperature if you're going for the time temperature method, and then you go for developing by setting the timer mechanism, and then you rinse it in the water, wherein the water that is being placed in the water bath, you have to place it for around 30 seconds, and then you go for fixing the solution, and then in the fixing solution you have to place it around for 2 to 4 minutes. After that you wash it in the running tap water itself, and then for at least for 10 minutes that has been washed in such a way that it tries to remove all the residual processing solution, and then it's left to dry. So these steps you can read it through in the textbook of White and Farrow. And the next question in this that has been asked is the processing errors, which I've already mentioned in the previous slide. Next question that has been asked in the short note is automatic film processing. Automatic film processing is nothing other than automatic dunking models, which helps to produce a washed film that can be still be dried up. So you don't need to manually do the processing in this. You just have, there's this kind of a there's this automatic film processor wherein we have a film entry. We just have to place a film within it, and then it tries to go from one solution to the next, that is from developing solution to the fixing solution. Then it goes for the water wash, and through with the help of the rollers that are being placed, that helps to move the film from one solution to the over to the other. The advantages of this automatic film processing is that the processing is found to be less than 4 to 7 minutes, unlike your manual processing, and there's a uniformity for processing this in each solution, and there is also no wet films that has to be handled. Density and contrast is found to be consistent, and there is less flow space required for the automatic film processing. The disadvantage is that it is found to be a high cost of equipment and maintenance. The quality is not as high as manually developed radiographs. It can also have a tendency of more grains that can be found in the final image. To know the mechanism of the processing of automatic film processing, you can go through this chapter in White and Farrow itself, where they have explained each how the transport system of this developing or the fixing of the solutions are occurring in each of the each solution. How is the film being processed? That all has been mentioned under this mechanism of automatic film processing. In function of these rollers are found to be their motion helps to keep the solutions agitated, which contributes to the uniformity of the processing. And then the developer, fixer, and the water tanks, the rollers press this film emulsion, forcing some solution out of the emulsion. So the emulsions rapidly fill again with solution, thus promoting the solution exchange itself. So finally, the top rollers at the crossover point between the developer as well as the fixer removes the developing solution itself, minimizing the carryover the developing into the fixer tank. So that is why we avoid the water rinse part in this when compared to that of the manual method. In the manual method, you have, there's a developing solution, then the water rinse and the fixing solution. This water rinse property is being taken up by the rollers itself that are found in the automatic film processing. So that is why in between the developing solution and the fixing solution, there is no water rinse process in this. So that is the difference between the manual processing from that of the automatic film processing. Then the next question that can be asked is the film processing. You can mention about the manual processing, then you have the automatic processing technique, and then the daylight processings. Then the next question that can be asked for short notes is the penny coin test. So the penny coin test is nothing other than to test the safe light condition in the dark room. So what we do is that such a way that onto the film itself, you place it in the dark room, the film with the coin over it, which can be placed for a few minutes, and then later in the darkroom setup itself, we try to process that film. Once you see a coin that is processed in the film itself, on the film image, then it indicates that there is no optimum safe lighting in that darkroom. So that is how it tries to assess the safe light condition in the darkroom setup. Next is a question that can be as a developing solution, that can be asked as a composition of it. You can speak about like how I already earlier mentioned, the components, the ingredients in it, and then the functions of each. Even sometimes fixing solution can also be asked similarly. So you can go about through the same way. Next chapter is about the intraoral radiographic techniques. So the short essays that can be asked is the object localization techniques. So under the object localization techniques, you have the buckle object rule, that is the tube shift or the Clark's technique, which can also be asked as a short note itself, which has been, I have already mentioned here with the diagram of what is tube shift technique or the Clark's technique. You can see here the tube shift technique, that is it follows a slob rule. Slob nothing other than same side lingual, opposite side buccal. So you can see here, once there are two objects, that's a foreign objects are being placed either side of the tooth, that is the lingual and the buccal. Once the X-ray is beam has been entered through this and then it hits the film, you will see here it is coinciding, the buccal as well as the lingual object, foreign object is coinciding in the same position. Once you try to move this tube head more distally, what happens over here is that the lingual is found to be positioned onto the same side as that of the distally it has been placed. That is, you can compare to the previous image. Whereas in the buccal, the object is found to be placed in the opposite side. When you compare it to the position of the tube head, you are saying that from the opposite there is found to be buccal. If it is found to the lingually object, the foreign object that is being placed, it comes towards the same side as that of the where the tube is being shifted. So that is why it's called as a tube shift technique or the Clark's rule technique as such. Next is about the right angle technique. In this, the right angle technique, what happens over here is that you take two projections that are placed at right angles to each other to localize that object in the maxilla or the mandible. So one radiograph that you take is the periapical radiograph, just to show the position of the object supra-inferiorly and antero-posteriorly. Next you take is the occlusal radiograph, wherein it shows the objects buccolingual and the antero-posterior relationship. So then you compare these two, that is a periapical radiograph from that of the occlusal radiograph, so as to localize the objects in a three-dimension way. That is what is about the right angle technique. Then you have a stereoscopy, which helps to determine the small intracranial calcification and foreign bodies in the dense or thick sections. So stereoscopic imaging, it helps to expose the two films, one for each eye, so as to deliver twice the amount of radiation to the patient. So between the exposure, patient is maintained in position, film is changed, and the tube is being shifted from right eye to the left eye position. So after processing, the film that are viewed with the stereoscope is used with the either the mirrors or the prisms, so as to coordinate the accommodation and convergence of the viewer's eye, so that the brain can fuse the two images together. So then you can assess the, now in cases of mandible, you can assess the mandibular canal to that of the root of the unerupted mandibular third molars. Even in the cases of any assessment of bone shape, when placement of dental implant can be considered under this technique. Next, you have the occlusal radiograph techniques and the indications. The indications for occlusal radiographs are to locate any retained roots of the extracted teeth, to locate any calculi or salivary stones in your mandibular sections, mandibular occlusal radiographs. Then you have to locate the foreign bodies and also to locate any supernumerary or unerupted or impacted tooth, to evaluate the cyst extension as well as the tuber in the maxillary and the mandibular occlusal radiographs. Techniques in the maxilla, you have three techniques, and in the mandible you have three techniques. That has beautifully been described in Frenny Karjotkar itself, and also even in White and Farrow under the chapter Intraoral Projections itself. They have a diagram as to how the projection has been done, and you can go through that. And along that, when the question is being asked for any describing the technique, you have to start off always in such a way that you speak about the image field, then how the X-ray film has been placed, and then the projection of the central ray and the point of entry. So you can go through the chapter in intraoral projections in White and Farrow itself. They have explained it well. All the occlusal radiograph technique, you have three types in the maxillary and three types in the mandible. Anterior maxillary, you have the topographic maxillary, then the lateral maxillary. The mandible, the similar one, it's the anterior, topographic, and the lateral. So just go about it and always answer the 4 points, that is image field, receptor placement, then the projection of central ray, and the point of re-entry of the central ray. Then next question that can be asked is intraoral radiographic technique. Once this question has been asked, you can formulate periapical radiography, bite-wing radiography, and the occlusal radiography. Periapical radiography, you have two types of techniques, that's a paralleling technique and the bisecting angle technique. Please draw the diagram along with that, how the paralleling technique is, how the bisecting angle technique is. Most commonly they ask the bisecting angle technique, and also you must know the other name for bisecting angle technique is short cone technique. Paralleling technique is other name is the long cone technique. Then you have the bite wing radiography and occlusal radiography, which I have explained in the previous slide. As I said, bisecting angle technique, the other name is called as a short cone technique. Once this question has been asked, you should draw the diagram like this, and along with that you should speak about what rule does it follow. It follows the Cisanki's rule of isometry. So in the rule of isometry, what it means is that you have two triangles that are being formed. Okay, so the two triangles, the one is the long axis of the tooth and one is the X-ray film that is being composed over here. You have the perpendicular bisector to this. So you can see here this central ray of beam that passes across here, it passes in such a way that it is perpendicular to this perpendicular bisector. And what happens over here is that you can see here, once this perpendicular bisector bisects this triangle or the angle, it bisects it in two equal angles. So you have a two equal angles as well as a common side. That is what this rule of isometry is supposed to be. And in this, once they ask you question, again as I've said, you have to speak about how the film is being stabilized, that is you stabilize it with the help of a snap array. Position the patient in such a way that once you're taking a maxillary radiograph, you try to place the occlusion plate is found to be parallel towards to that of the floor. And the vertical angulation, it depends on each of the which tooth is being taken or tooth of interest. It is highly based on that the vertical angulation. And then horizontal angulation is nothing other than central ray that is directed through the contacts of the or the proximal contacts of between the tooth. So it is found to be 0 degrees. Again, the question of occlusal radiographs when asked, as I've already mentioned, what are the occlusal radiographs, what are the indications you have to mention, techniques each you have to mention based on the 4 categories, that is the image field, the receptor placement, then the projection of central ray as well as the point of entry. So this is a classification of the maxillary and the mandibular. You have the anterior, you have the topographic, and then you have the lateral. Bite-wing radiographs when asked, you can say that it is used to detect the interproximal caries. So the indications are to detect the interproximal caries, to check the alveolar crest levels between the two teeth, that is the periodontal conditions are being detected so and so, and also to mention the change in the bone height based on the alveolar crest levels, and if any calculus is found in the interproximal areas. And the patient position is such a way that the maxillary arch is found to be parallel to that of the floor, and the mid-sagittal plane is found to be perpendicular to that of the floor. And you can see here the bite wing is being placed such a way with the bite tab, which is where the patient is asked to bite the bite tab over here, and the X-ray beam is directed in such a way that the vertical angulation for the molars exposure, it is found to be plus 10 degrees, and for the premolars it is found to be plus 5 degrees of angulation, and the horizontal angulation is such a way that it is directed through the contacts of the teeth. So again, the question has been asked about indications of bite-wing radiographs, which I have already explained. Next chapter is about the extraoral radiographs and the other specialized imaging techniques. So the short notes can be asked into this chapter is the subendo vortex and the jug handle view. Once the question has been asked about extraoral radiographic techniques, you should follow these headings. It's a film placement, the position of the patient, the central ray, point of entry, and the exposure parameters. So the film placement is such a way that the cassette is being placed perpendicular to the floor, and it is found to be log axis of the cassette is found to be placed vertically. And the patient position is such a way in submental vertex is that the vertex of the head portion is supposed to touch the cassette, and the mid-sagittal plane is found to be perpendicular to that of the plane of the film. And the central ray is directed in such a way that it is perpendicular to the film and through the mid-sagittal plane. So as you can see here, almost around a vertical angulation of -5 degrees is being given. And next to the modification of submental vertex view, there is a jug handle view. And sorry, I have not mentioned over here the indications of submental vertex view is such that helps to check for the fractures or any tumors of the zygomatic arches. Also, to check of any skull base tumors also you can see in the cases of submental vertex. Whereas a jug handle, as the name suggests, jug handle, it is found to indicated for the view of the zygomatic arches. As you know, the when it is viewed, it is found to be almost similar to that of the how you have a handle to the jug, and that's why it's called as a jug handle. The zygomatic arch represents as a jug handle itself. So in this, the only difference is that it's the technique and everything, the patient position is all the same. Only the exposure parameters are different from that of the submental vertex. In jug handle, at least 50 to 60 kVp of exposure, as well as the milliamperage is around to 5 to 9 milliamperage of tube current is being given, and the exposure time is found to be less than around 50 seconds. So that is why the difference between the submental vertex from that of jug handle, the exposure parameter wise is the difference only between the either of the two. And you can view in this the zygomatic arches. If there is any fractures to the zygomatic arches, that you can be indicated for jug handle view. Next is the transpharyngeal projection of the temporomandibular joint. In this, again, the film is placed in such a way that the cassette is found to be placed against the patient's ear, where it has been centered half-inch anterior to the external auditory meatus, and then it is placed also over the TMJ of interest parallel to that of the sagittal plane. And the patient position is such a way that the sagittal plane is vertical and parallel to the film. And you ask the patient to open their mouth wide. The central ray has been directed at an angle of -5 to -10 degrees posteriorly. So the central ray is oriented in such a way that it hits against the mandibular notch or the sigmoid notch of the opposite side below the base of the skull. Next question that can be asked is the paranasal sinus views. So again, you can all these extraoral radiographic techniques you can read from the textbook of Freddy Karjotkar itself, where they mentioned it properly along with the following headings, as I've already mentioned. What are the indications for it? What are the patient's position? How the film is being placed, and also how the central ray is being directed. And then the next is the exposure parameters to be given for each view. So might as well follow from that textbook itself. In the paranasal sinus views, again it is used to study the relationship of all the paranasal sinuses. You have the PA projection, wherein you have the other name is the Granger's method, and then you have the Caldwell's modified method of the posterior anterior projection that has been given in the textbook itself. You can read about it from the textbook of Freddy Karjotkar itself. Next question that can be asked is xylography. This can be asked as a long essay itself. So you can read again from the textbook of Freddy Karjotkar itself, where she has mentioned in the salivary gland tumors chapter or salivary gland diseases chapter itself, she has mentioned beautifully what xylographic technique is, and you can draw the relevant diagrams related to that. Xylography is nothing other than a radiographic procedure that is used to as in diagnostic agent to monitor salivary gland diseases, and it helps to examine the ductal as well as the acinar system of the major salivary glands. That is your submandibular salivary gland as well as your parotid salivary glands. The indications for xylography is that it detects the calculus. It helps to detect the extension of the destructed glands secondary to the obstructed calculi or any foreign body is being placed. It also helps to detect the fistulae or the strictures, and also it helps to demonstrate the tumors as well as it diagnose the recurrent swellings. So, in the procedure of xylography, you have three main steps, that is, preliminary plain film evacuation, then you have the injection or the filling phase, and then you have the evacuation phase. So, you have to explain in each phases what are the procedures that has been done. So, in the preliminary, radiographs have been taken to detect the conditions without any requirement of any contrast. And then secondly, what we do is that we, in the filling phase, we try to ask the patient to consume the secretory stimulant for around 2 to 3 minutes, that is by asking them to suck a lemon wedge or so, and this helps to open the ducts for easy identification. Then next what we do is that in the ductal orifice itself we spray the topical anesthetic, and this the duct is then xylographic cannula has been inserted to this duct. Then the contrast has been introduced into this cannula itself, that is slowly it has been introduced in such a way that 0.76 to 1 ml of the contrast media has been given, that is the oil based or the water soluble iodinated has been given or injected, and then the images are taken immediately after the contrast has been completed. And once the images have been taken, the patient is asked again to suck the lemon wedge so as to evacuate the contrast in such a way that the cannula has been removed, and then we take the radiographs of the patient of the salivary gland itself almost 5 minutes after the removal of the cannula. So this is what the xylographic technique is all about. Thank you. We'll take up for the next session the other chapters. Good day to all. Welcome to another session of dentistry and more. Today we will be discussing further about question paper discussion on oral radiology. So the topics that will be discussed are these: panoramic radiographs, digital radiographs, normal anatomy on intraoral and extraoral radiographs, then followed by dental caries, periodontal disease, and the inflammation and infectious diseases. So the first chapter we are going to speak about is the panoramic radiographs. So the question that can be asked is the, in short notes, indications of oral. So the indications are enlisted as further here. It is used as a substitute for full mouth intraoral periapical radiographs. It is used for evaluation of tooth development for the orthodontic purpose, and also to cite and see the size of the lesions such as cysts, tumors, and developmental anomalies in the body and the rami of the mandible for any detection of oral fractures, as well as the middle third and the mandibular fractures after the facial trauma, followed by the assessment of periodontal diseases, then the developmental anomalies that I've already mentioned previously, and also for assessment of the underlying bone diseases before construction of complete or the partial dentures. So the next question that can be asked as short essay is the principle of a panoramic radiograph. We have to draw a diagram with respect to this, and you can refer from the textbook of Oral Radiology by White Farrow, in which they have given a beautiful diagram representation. In this, when you're talking about the principle of the panoramic radiograph is such that the X-ray tube head as well as the film is moved around the patient. So the patient is meant to be stationary. So the X-ray moves around the patient's head in one direction while the film rotates in the opposite direction, and the patient is seated or standing in a stationary position. The movement of the tube head and the film produces an image through the process of tomography, and this curvilinear variant of conventional tomography is also based on the principle of reciprocal movement of an X-ray machine or the X-ray source and the image receptor around a central point or plane, which is called as the image layer. So you can see here in this diagram there is a center of rotation where the patient's head is stationary, and the X-ray tube head moves around one side of the patient and the receptor assembly moves towards the opposite side. The image receptor slides pass the collimator, sequentially producing a latent image, and there is a charge coupled device image receptor, wherein there is a vertical charge coupled linear array behind the collimator that continuously reads out the exposure to produce an image. Next, the question that can be asked is as panoramic radiograph as such. So once you start off with the answer, you start off with the principle of panoramic radiograph, which I've already previously mentioned with a diagrammatic representation, followed by the procedure and how the procedure is done. That is, the patient is asked to wear a lead apron without the thyroid collar and load the panoramic film in the darkroom and cover the bite block with a disposable plastic cover slip. In the center, the lower border of the mandible on the chin rest and at an equidistance from each side. Instruct the patient to sit or stand and with the back rest straight and erect, and ask the patient to bite the plastic bite block, followed by the mid-sagittal plane of the patient should be perpendicular to that of the floor, and instruct the patient to stand in such a way that the tongue is resting on the palate, and ask the patient to remain still while the machine is rotating during exposure. After the exposure is complete, the film is subjected to routine processing. So the common errors that are seen in the panoramic radiographs are the ghost images. Ghost images are nothing other than those objects that are located between the X-ray source and the center of the rotation. These objects can cast some ghost images. So the ghost images can appear on the opposite side of the true anatomical location and at a higher level because of the upward inclination of the X-ray beam. So in this, there are other images such as that of real images and double images and all, which you can be reading it about in the chapter on panoramic imaging. In White and Farrow itself, they have beautifully described what is real images, what are the double images and the ghost images with the radiographs given. And then you can speak about the patient positioning errors. The patient positioning errors, that is based on the proper placement of the patient as well as the positioning within the focal trough, which is necessary for the diagnostic panoramic radiographs. Once it is out of the focal trough, there are certain images and errors that can be seen, such as that of the placement of the patient, which is either further anterior or too posterior in relation to the focal trough. It results in certain aberrations in the images. So once if it is too far, it is found to be magnified in the mesiodistal dimensions, so it looks like a fat teeth. Whereas if it is placed anterior, the patient is positioned anterior into the focal trough, it is found to have a reduced mesiodistal dimension in the anterior sextans. So all these are the errors that can be enlisted. Cassette positioning errors also has been explained in this chapter itself. We can read about, and the indications I've already mentioned in the previous slide. Next is about the advantages and disadvantages of panoramic radiograph. Advantages: it's a simple procedure, it is convenient for the patient, and the patient dose is found to be low, minimal when compared to that of the full mouth intraoral periapical radiographs. And then it's found to be useful in patients with trismus as well as gagging problems, and also the time is found to be minimal when compared to that of the full mouth intraoral periapical radiographs. The disadvantages are found to be that there is an overlapping of the teeth in the bicuspid areas, and also the areas of diagnostic interest outside the focal trough cannot be properly be visualized, or it is poorly visualized, and comparatively there is a poor diagnostic quality when compared to that of full mouth intraoral periapical radiographs. So the next chapter is about the digital radiographs. In the digital radiographs chapter, you can refer again from the textbook of Oral Radiology by White and Farrow, where they have explained about all the sensors that are being used in the digital imaging. So once the digital radiographs are such a question has been asked, you have to mention what is digital radiograph. Is that method of capturing a radiographic imaging using a sensor, breaking it into electronic pieces, that is pixels, and they're presenting and stored in the image as with the help of the computer. So the methods that are found to obtain the intraoral digital image are the direct sensors and the indirect sensors, as well as the storage for imaging. So the methods that are used to obtain the extraoral digital images are the photostimulatable phosphor plates based radiography and the charge coupled device systems. So in each we have to explain about what is direct detectors and the indirect detectors. Direct detectors and the indirect detectors are found in the flat panel detectors. So in direct detectors, we use a photoconductor material, that is selenium, and this is found to have a similar property of that of silicon and high atomic number, which permits more efficient absorption of X-rays. Under the influence of this, the electrons that are freed during the X-ray exposure of the selenium is conducted in a direct line to that of the underlying thin transistor, that is a thin film transistor detector element. So in the indirect detectors, what happens is that once the X-ray photons or the X-ray has been exposed to these sensors, what happens is that it is found to be sensitive to, these detectors are found to be sensitive to visible light, and it has an intensifying screen that is made of cesium iodide and gadolinium oxysulfide, which helps to convert the X-ray energy to light. And the performance of these devices is determined by the thickness of the intensifying screens. So thicker the screens, the more efficient, and it allows more diffusion of light photons, leading to a less sharper images. So that is what is with the indirect conversion or the indirect detectors. So we have to explain in this each of the mechanism that is related to the charge coupled device, then the complementary metal oxide semiconductors, flat panel detectors, and the photostimulatable phosphors. So how is it working? The working principle of each of these has been explained well in the with the diagrammatic representation in the textbook of oral radiology by White and Farrow, that you have to draw on this once it has been asked, and then you have to speak about the advantages of the digital radiography over the conventional one. So the advantages are found to be the superior grayscale resolution, it is easily reproducible, there is an increased speed of image viewing, there is reduced exposure to radiation, lower equipment and film cost, and then there is an increased efficiency, enhancement of the diagnostic images, and also it improves and has an excellent quality of the image. The disadvantage is that the sensor is found to be thicker, so it will be inconvenient for the patient to be placing the sensor within their mouth. The image quality is found to be a source of debate when compared to that of the conventional radiographs, and the initial setup is found to be more costly. In the infection control, the sensor has to be covered with a disposable plastic wrapper, and there are also legal issues because the original digital image can be manipulated as such when it is being utilized. So the next chapter is about the normal anatomy in intraoral as well as extraoral radiographs. And in that, the question that can be asked is the significance of lamina dura. Once the question has been asked, you can speak about what is lamina dura. It is nothing than the part of the alveolar bone that is surrounding the tooth socket, which is thin layer of cortical bone, which is found to be normally radioepic, which is found to be a continuous band that covers the alveolar crest of the bone, and it surrounds the tooth socket. So when there is an increase in the occlusal stress, the lamina dura is found to be more wider and denser around the roots of the tooth. And there is a presence of lamina dura around the root apex if there is a vital pulp. If it is the vital pulp is absent, that is if it is non-vital, this is found to be disappeared. The condition that can be associated with the lamina dura is the periapical lesion that you see in cases of periapical abscess, periapical granuloma, and cyst. There is a loss or absence of lamina dura, and in the periodontal diseases, as such, you might see a wider or a thicker lamina dura when there is an increased in the occlusal stress. Same goes with the orthodontic tooth movement, and in the external root resorption also you can see there is a continuous lamina dura that has been seen. Osteosarcoma and the squamous cell carcinoma, mucoepidermal carcinoma, traumatic bone cyst, Paget's disease, hyperparathyroidism, fibrous dysplasia, and rickets. In these conditions, you might see the changes in the lamina dura. So we have to know what are the all the conditions that are associated with the changes in the lamina dura as such when asked this question. Next chapter is about dental caries. The question that can be asked is the radiography features of the dental caries as well as the periodontal disease. So the radiography features of dental caries is such that the caries appears as a radiolucent areas. So according to the severity and extent of the lesion, it is divided into proximal caries, whether in incipient proximal caries, the early lesions that cannot be seen because of the extension of the more than the half of the thickness of the enamel should occur, then only you can see there is some radiolucency around. And such incipient proximal caries, it appears as a classical triangle which is having a broad base at the tooth surface and spreading along the normal enamel rods. In the moderate proximal lesions, you will see that it is involving more than outer half of the enamel but does not extend to that of the dentino-enamel junction. In the advanced proximal lesions, these are found to be invading the dentino-enamel junction, which is found to be appearing as a second triangular radiolucent area in the dentin, with the base at the dentino-enamel junction, and the apex of the triangle is directed towards the pulp chamber. And the severe proximal caries, you see that it is found to be penetrating more than half of the dentin and is approaching the pulp chamber. So according to the location on the tooth, pit and fissure caries, that is occlusal caries, when the severe occlusal caries are there, you can see a radiolucent area which is involving the pulp. And in the buccal, facial, lingual and the cervical areas, it is found to be elliptical or semilunar and the lesion enlarges. So in buccal facial caries, it is not detected in the intraoral periapical radiograph. As you know that in the intraoral periapical radiograph is a 2D image, not a 3D image. So you can only detect the mesial as well as the distal caries or the occlusal caries as such. And then the root surface caries, you will see it appearing as an ill-defined saucer shape like crater or notched radiolucency. And recurrent caries or the secondary caries, you see a radiopacity, that is the restoration, that is the underline the restoration or underline the radiopacity, you have the radiolucency. Then the rampant caries, it is found to be an extensive intraproximal caries that are seen involving whole of the primary dentin. So where it is appearing as a radiolucent structures. And then you have the radiation caries which appears around the necks of the teeth. And then pre-eruptive caries, which is found to be defects of the crowns of the developing dental teeth that are found evidently around the radiographic method. Next chapter is about the periodontal diseases. When the radiographic features of periodontal diseases is being asked, it can be divided into mild periodontitis, moderate periodontitis and the severe periodontitis. In the mild periodontitis, in the anterior region, it is found to be appearing as a blunting of the alveolar crust, whereas in the posterior, it is found to be the loss of the shape of the sharp angle between the lamina dura and the alveolar crust, with the loss of cortical margin found to be as a rounded off with the irregular diffuse border. Moderate periodontitis, you see that there is a generalized horizontal erosion or a vertical or the angular defect that has been noted in the interdental area between the two teeth. Horizontal bone loss is nothing other than the loss of the height of the alveolar bone that is still horizontal or parallel to the occlusal plane, whereas the vertical defects is found to be an oblique angulation of the alveolar bone in the area of the tooth that has been involved. So there are different creation defects that can be notified, which is already been enlisted here, and you can refer from the textbook of oral radiology by White and Farrow under the chapter Periodontal Diseases, where they have given all the features, radiographic features that you see in each of these defects. So periodontal diseases chapter I have already mentioned earlier. What are the radiographic features for periodontal diseases? And next question that can be asked under this chapter is the role of radiography in the diagnosis of periodontal diseases. So you can use periapical radiographs, bite wings, as well as the orthopedograph, that is your OPGs also can be utilized. Wherein in OPGs for the generalized periodontitis, we can detect with the help of these radiographs. Bite wing and the periapical radiographs is found to be detecting for this localized areas or the areas where you see there are kind of any horizontal or a vertical bone loss is being detected interdentally, that can be seen under these two radiographs. And then under the digital radiography, you have something called as a digital subtraction radiography, wherein there is a subtraction radiography and a densitometric image analysis which help to assess the subtle changes in the alveolar crustal bone pattern. So in this, it allows the better detection of any small amounts of bone loss that can be detected between the radiographs made at different times. So the evaluation of periodontal therapy, in this the radiographs plays a important role for the treatment of periodontal diseases. So by detecting these with the help of these radiographs, you can find how much ever the bone loss is, and based on that we can do the assessment and analysis for the treatment plan. Next is the chapter about infections and inflammatory lesions and the systemic diseases affecting the jaws. Under this, the question that can be asked is the discuss the differential diagnosis of mixed radiolucent or the radiopaque lesions of the jaws. Under this mixed lesions, you can divide the mixed lesion, that is mixed lesion nothing other than a radiopaque as well as a radiolucent components are seen, wherein in the radiopaque component that's because of the deposition of mineralized tissue in that area where the normal bone is found to be removed and creating a space for the lesion, that is the radiolucent area. So the mixed lesions can be divided into associated with the tooth and non-associated with the tooth. In the association with the tooth, you have the pericoronal as well as the periapical. So in the pericoronal, you have the odontome, calcifying odontogenic cyst, calcifying epithelial odontogenic tumor, adenomatoid odontogenic tumor. Periapical, you have the calcifying crowns, the tooth roots with the rarefying mastitis, rarefying and condensing mastitis. Then you have calcifying post-surgical. Then you have the pericementosseous dysplasia and the cemento-ossifying fibroma. Under those lesions which are not associated with the tooth, you have the you have the fibrous dysplasia, Page's disease, then again osteosarcoma, chondroma, odontogenic myxoma. All these can be not associated with the tooth mixed lesions. Next, most favorite question to be asked is multilocular radiolucencies. Multilocular radiolucency is nothing other than locules that are seen within the lesion, and classify the multilocular radiolucencies of the jaws and discuss the differential diagnosis of multilocular radiolucencies in the body of the mandible. So once this question has been asked, there are three types, that is the soap bubble appearance, then the honeycomb pattern and the tennis racket pattern. You can refer from the textbook by Wood and Gauss in differential diagnosis of oral lesions. In that book, they have already mentioned what are the multilocular radiolucencies as such, and how does this appear also: soap bubble appearance, honeycomb appearance, and the tennis racket appearance, wherein you see the bony scepter that is found within the lesion which forms these locules, as well as you can see in tennis racket there is a scepter that is found to be at 90 degrees or the right angles to each other. So the pattern that you see, soap bubble appearance, is seen in ameloblastoma, botryoid cyst and the aneurysmal bone cyst. Honeycomb appearance is seen again in aneurysmal bone cyst, ameloblastoma, central hemangioma. Tennis racket is seen in odontogenic myxoma. So this is how the lesions appear. There is a multilocular radiolucencies that has been seen in a normal pattern itself. And the differential diagnosis that you can give is the odontogenic cyst, that is odontogenic keratosis, botryoid cyst, glandular odontogenic cyst, which can be given. And the odontogenic tumors are the ameloblastoma, odontogenic myxoma, central odontogenic fibroma. You can see here in the almost soap bubble appearance in the ameloblastoma. And in the non-odontogenic pathologies, you have the aneurysmal bone cyst, central giant cell granuloma, fibrous lesions such as that of cherubism. Next short note that can be asked is the radiography features in hyperparathyroidism. You see that there is an overall demineralization of the skeleton, resulting in the grayness as well as lack of normal contrast in the radiograph. So there is a generalized osteoporosis with abortive attempts at repair as well as new bone formation. So leading to a new bone being resorbed and then leading to the pseudocyst formations. So the generalized form of the hyperparathyroidism that you see is the osteitis fibrosa cystica, and they are found to be localized of regions of bone loss produced by osteoclastic activity, leading to a loss of all apparent bone structure. And then the other name is the Brown's tumor for hyperparathyroidism, that is found in the later disease. The density of the jaws is found to be decreased, resulting in a radiolucent appearance, and the teeth stand out in contrast. So demineralization and thinning of the cortical boundaries are found, and also there is a change in the normal trabecular pattern, leading to an appearance called as a classic appearance, that is ground glass appearance. And in the periapical radiographs, you see there is a loss of lamina dura generalized form. So we will be continuing further for the next session. Thank you. Welcome to another session of dentistry and more. We shall be continuing the last topic discussion for oral radiology. We'll be talking about these topics, that is cysts of the jaw, benign tumors of the jaw, malignant diseases of the jaw, diseases of the bone manifested in jaws, trauma to the teeth, as well as the facial structures. So under the first chapter, that is the cysts of the jaw, the short notes that can be asked are the radiographic features of the periapical cyst, or the other name is radicular cyst itself. So in the radiographic features of periapical cyst, there is a loss of lamina dura that is seen. Along with that, you can see there is a well-defined periapical radiolucency associated with the apex of the tooth, which can be more than 1.5 centimeters in diameter, and it has been enclosed with a sclerotic border, and you can see that there is sometimes rarely root resorption, that is external root resorption can occur in the affected tooth. Same goes with this question. Radicular cyst is also the other name for the periapical cyst itself. So once a radicular cyst, as such, the questions are being asked, you can start off with what is it? It is an inflammatory odontogenic cyst associated with the non-vital teeth, and the clinical features are that it can be seen most commonly around the maxillary anterior region, and it's a painless, bony, expansive lesion wherein you can see that there is crepitus that has been observed by non-palpation, and also when secondarily infected, the patient may complain of a symptom such as pain. On FNAC, that is on aspiration, you might see a brown to straw colored fluid. And the treatment on the clinic, these are the clinical features that has been extensively been mentioned here. And the radiographic features I have already mentioned in the previous slide, you can highlight about that too. And then the treatment is such as the root canal treatment is done, or an extraction can be done along with the enucleation of the cyst. Under the next chapter, the benign tumors of the jaws, the question that can be asked as a long essay is the classification of odontogenic cysts, which you can go through in the in any of the standard textbooks of oral medicine, such as that of Anil Gomes, or you can go through the other textbooks such as the Ravikiran Ongole itself, where they have given the classification that's given by Shears, where it has been classified based on the etiology, developmental, inflammatory, and also under that developmental and inflammatory, you have developmental dentigerous cyst, eruption cyst, the odontogenic keratocyst, gingival cyst of newborn and the adult, lateral periodontal cyst, calcifying odontogenic cyst, and the glandular odontogenic cyst. In the inflammatory, you have the periapical cyst, periodontal cyst, and the residual cyst. And based on the tissue of origin, it has been derived from the res of malaces, that is a periapical cyst, and the residual cyst. When it is derived from the reduced enamel epithelium, you have dentigerous cyst, eruption cyst, and then under the derived from the dental lamina or the cell rest of seres, that is the odontogenic keratocyst, the gingival cyst of the newborn, gingival cyst of the adult, lateral periodontal cyst, then the glandular odontogenic cyst. And the ones that are unclassified is the periodontal cyst and the calcifying odontogenic cyst. And then the second part of the question is to explain in detail about the clinical and the radiological features with management and complications of dentigerous cyst. First, we can speak about what is dentigerous cyst. It is a cyst that has been arising from the enlargement of the follicular space of an unerupted tooth or an impacted tooth, which is attached to the tooth neck. And then the clinical associated with the crown of the impacted tooth, and is most commonly seen in the mandibular and the maxillary third molars, as well as the maxillary cuspid region. It is found to be a solitary lesion which has expansion with a facial asymmetry, and also root resorption is seen with the adjacent tooth. The radiological features, there are three types, that is the central, lateral, and the circumferential. The central, when it envelops the crown portion, and then you have the circumferential, which encloses the whole of the crown, and then you have the lateral, which is found to be lateral to the tooth itself. So it is found to be a radiolucent area within which is associated with the unerupted tooth or the impacted tooth. Then the next chapter is about the malignant diseases of the jaw. Yes, and the management of the dentigerous cyst is nothing other than enucleation or massopilization that has been done for the cyst, along with the removal of the tooth affected. That is, a impacted tooth has also been removed along with it. And the complications is that once it is left untreated, it can lead to ameloblastoma as such. Then the next chapter is about malignant diseases of the jaw. This is mainly a oral medicine topic. So, when the question has been asked about adenoid cystic carcinoma, you can speak about what is it. It's a malignant tumor of the salivary gland, which is most commonly seen as a second most common, and it is most commonly affecting the submandibular, sublingual, as well as the minor salivary glands. And the male to female predilection is equally distributed, and also it is found to be occurring in the fifth decade. And the clinical features is that it is most commonly affecting the palatal region because of the involvement of the minor salivary glands, and also it is found to be an asymptomatic slowly enlarging mass, and the parotid is most affected, so in which you can see a facial nerve paralysis also along with it. So the treatment for such a case is that surgical excision is supposed to be done for such a carcinoma case. Chapter is about the diseases of bone manifested in jaws. Most commonly, they can ask a long essay. I've already mentioned the oral medicine part, that is the classification of fibrous lesions, and also write in detail about the fibrous dysplasia, where I've already explained about in detail what are the how to go about for fibrous dysplasia, how to explain about it. Next, that can be asked as a short note under this chapter is the moth-eaten appearance. So the moth-eaten appearance, you have to say in which cases scenarios do you see moth-eaten appearance. You see it in Burkitt's lymphoma, chronic suppurative osteomyelitis, osteosarcoma, osteoradionecrosis too. And how does this appear? There's a wide areas of the bone destruction with sequestrae that are seen, where there are zones of radioopacity separated from sequestrae by zone of radiolucency. And then you can see a scattered areas of bone destruction of different size and number, which are separated by variable distances. So you can see here in the skull vault the moth-eaten appearance. So the next chapter is about the trauma to the teeth and the facial structure, which is the last chapter of this oral radiology discussion. So the question that can be asked is the radiographic diagnosis of facial trauma. So you can refer from the textbook of oral radiology by White and Farrow under the chapter trauma itself. So they have also mentioned in the first part of the page itself about the applied radiology in relation to the fracture cases, where you can speak about the radiological signs of the fractures. There are about general signs that have been given enlisted here around 4 types, wherein you can say that there's a presence of 1 or 2 sharply defined radiolucent lines with the anatomic boundaries of a structure, and then next is about the change in the normal anatomic outline of the shape of the structure, which can define as a look, and we can indicate the presence and the location of the fracture in that. And then there's a loss of continuity of an outer border, whereas a step type defect is seen, that is a gap in the continuity of the smooth tooth or the cortical border that is seen is called as a step type defect. And then you have an increase in the radio opacity is nothing other than overlapping of 2 fragments of the bone or the tooth, wherein it forms as a doubly radio opaque, that is more, it has more increased radio density is seen, that is radio opacity is seen more. So these are the radiological signs to relate to fracture cases. And so how to detect the trauma cases? It is seen in detection of the soft tissues and bone injuries, which can be indicated through the MRI scans. And then CT is more preferred over the normal conventional radiographs. And the standard radiographic projections that we use for facial trauma that is indicated as the anteroposterior or the posterior anterior views, then the Caldwell's and the Waters, that is for indicating any sinus, paranasal sinuses, if it has been indicated in the fractures, that is what these projections have been indicated for that. Then you have the Townes projection and the lateral projection, where you can see if there is any mid-third fractures can be indicated for such cases. So with this, we end up the oral medicine and radiology discussion of the question papers. Thank you for your kind listening.